Good morning, everybody. Welcome to General Surgery Grand Rounds. There is no commercial support for today's program. Any financial relationships of the planners and speakers with commercial interests have been mitigated. A link to the evaluation will be passed out and posted in the chat. If you are ABS certified and want us to report your CME credits, please fill out the evaluation and give us permission, and we'll do that. If you have a question for the presenter, please hold until the end of the talk. If you're attending virtually, you can enter your questions into the Q&A section. And now it is my pleasure to introduce our speaker for this morning. Dr. Samuel Berding is a PGY4 resident in the general surgery program at Northeast Georgia Medical Center. He earned his Doctor of Osteopathic Medicine degree from the Philadelphia College of Osteopathic Medicine, the Georgia campus. Dr. Berding has chosen to pursue a fellowship in vascular surgery and recently matched at Maine Medical Center in Portland, Maine. He has a strong interest in surgical education and values teamwork and hands-on learning in clinical training environments. Please join me in welcoming Dr. Berding.
So today my Grand Rounds presentation is on carotid occlusive disease. This is something that I'm definitely very interested in, just going into vascular, and I think it's a fascinating disease topic, but I think it's something that we all need to know as general surgery residents, at least in part for our board exams, and just because it's a disease that's very prevalent in our population. It might be something that ends up affecting some of your patients down the road almost assuredly in your career, and it affects a lot of people's loved ones and people they care about. So I think it's something that's important to know about. So I don't have any disclosures for this presentation. So kind of what I was alluding to, it's very prevalent in our U.S. population. About 800,000 people a year suffer from a stroke of some kind, and about 15% of these are in part due to carotid occlusive disease, and which are potentially a source of preventable strokes. The total annual cost of this is $56 billion a year, but that doesn't even begin to cover lost productivity, informal caregiving, or psychological burden on family members. So it's something that's pretty devastating and I think is very important for us to know about. I included this quote here from one of the pioneers of carotid occlusive disease. I thought it was pretty interesting. It is even conceivable that someday vascular surgery will find a way to bypass the occluded portion of the carotid artery during a period of ominous fleeting symptoms. And this was written just a few years before the first carotid endarterectomy was even performed. So I thought that was pretty neat, just to show how far we've come in this field. Let's see. All right, so a little bit about the anatomy and why we develop carotid atherosclerosis. So everyone here is familiar with the anatomy, but some of the real interesting portions of this is where the flow dynamics begin to change in the carotid bulb. So from the carotid bulb to the ICA, there's a change in the diameter of the flow dynamics. So this creates a few things that contribute to atherosclerotic disease. So there's flow deceleration in the carotid bulb, there's low average time wall shear stress, and that leads to endothelial dysfunction and ultimately leads to LDL deposition, macrophage infiltration, and then ultimately forms plaque. The most common location of formation of plaque is in the outer wall of the bulb. And the dominant mechanism by which people have strokes from carotid occlusive disease is actually from embolic disease. So about 75% of strokes from carotid occlusive disease are actually caused from emboli from the carotid plaque rather than just a state of low flow. And this kind of explains why a patient with 60% stenosis can have frequent TIAs because their plaque is ulcerated and is showering microemboli. And it also tells us why a patient with 95% stenosis can really have zero symptoms from this. So I think that's an important point to know about this disease as well. And I think ultimately at some point in the future, our field will be moving more towards stenosis, from stenosis-based stenosis-based treatment to really plaque biology-based treatments. And that'll kind of guide some of the patient selection in the future. All right, so a little bit about the history of carotid surgery and how we got to where we are today. So one of the first pioneers was Dr. Wepfer. He was a pathologist and a pharmacologist in 1658. There was a disease called apoplexy, which in the Greek origin just meant to be struck down and suffer death from being struck down. And he was really one of the first persons to really document that this was being in part due to vascular obstruction. He did meticulous autopsies on patients and discovered that there was a physical blockage in the blood vessel, possibly contributing to this disease. One of the other pioneers was Dr. Gowers, and he really was the first person to identify TIAs and gave us an understanding of what TIAs were and how that could be a harbinger of the nature of these events. Oh, sorry. And then one of the other main pioneers was James Hunt. So he first described intermittent claudication of the brain. So he almost made an analogy to peripheral vascular disease and how the same thing may be happening in the brain with carotid occlusive disease. And it really gave us an understanding of the basis of the pathology. And then Dr. Moniz developed cerebral angiography, which is essential to treating carotid occlusive disease, and gave us a better way to characterize the lesions. The main contributor and almost like the father and pioneer of carotid occlusive disease is Dr. Miller Fisher. He wrote 3 papers in the early 50s describing occlusion of the carotid artery. And it's really important that in some ways he was not a surgeon, he was a neurologist, but he really laid like the intellectual groundwork for carotid occlusive disease and gave us a framework on how to treat patients with a carotid occlusive disease. The way he did this, he followed patients with TIAs through their clinical course, and when they died from stroke or other causes, he would perform an autopsy, and he would specifically open their carotid arteries and was able to demonstrate that a lot of these patients had a significant plaque burden in their carotid artery. And his description of plaque was actually very accurate to this day. He described ulcerated thrombotic plaques in the ICA origin, and he found that those were occurring on the same side as these patients' TIAs and strokes. So he was the one who really made the connection for us and gave us a framework on how to begin understanding and treating this disease. He was also the first person who suggested that we could maybe cure this disease by bypassing that segment or taking out that occlusion. So he kind of laid the groundwork for surgeons to be able to operate on it. The first surgeons to perform a carotid endarterectomy, it's a little bit debated, but Dr. DeBakey gets the credit, really. He performed the first carotid endarterectomy in 1953. He just didn't publish it till 1975. And then concomitantly over in Europe in 1954, they immediately published their CEA case report. So these were really coming out at just about the same time, but ultimately Dr. DeBakey got the credit for performing it first. So Dr. DeBakey's patient in the surgical record presented with recurring right hemispheric TIAs and episodes of visual disturbance, which is classic of ipsilateral carotid disease. And he noted that there was stenosis at the ICA origin and performed really what we recognize as an endarterectomy today. The patient's recovery was complete and went on to live without symptoms for a long time. And then in the Escott case, they described a patient that had 11 TIAs in 11 months and was really believed to be at an imminent risk of suffering from a devastating stroke. So they elected to perform an operation on her, and she got 15 more years of life without ever having another symptom. So really, both of these cases were landmarks in carotid occlusive disease and really were the first successes of performing surgery on carotid occlusive disease. So everyone's familiar with the steps of a carotid endarterectomy, but there are some, the surgery has changed obviously since the first operations, and I think nowadays there are a few considerations that we think about in every patient with carotid occlusive disease undergoing surgery that maybe they didn't think about then, or didn't know enough about then. So I have four kind of points listed over here on the right-hand side of the screen, which really we think about in the modern day age, which they probably weren't even considering back then. So some studies have come out showing that patch angioplasty is far better for patency rates and restenosis rates, which is something that we do routinely on almost carotid nowadays, which they didn't necessarily do back then. Now we can also use things like selective or routine shunting. Some operators routinely shunt every single patient that they perform a carotid endarterectomy on, with a slightly increased risk of increased microemboli from that, but other surgeons will use it selectively. So if they see something intraoperatively that kind of prompts them to deploy a shunt, which would be things like an EEG monitor with greater than 50% amplitude changes, low stump pressures, or if you're performing an awake carotid endarterectomy, having neurological deficits. And that brings up the point of general anesthesia versus regional anesthesia. So awake carotid endarterectomy is really the most sensitive and specific method to detect neurological deficits during a carotid endarterectomy. I would say it's not performed very frequently, but it is definitely an option. So I would say most patients undergo general anesthesia, but regional anesthesia is an option for patients. And then intraoperative monitoring, if you're not doing an awake carotid endarterectomy, you can use things like transcranial Doppler, which will detect microemboli. And the typical rate of microemboli during a carotid endarterectomy can be 10 to 30 events, with that still being normal. We use EEG here, and that's one of the most common methods used in today's day and age. And then you can use stump pressures and then awake exams. So after the initial, not advent, but I guess after the initial carotid endarterectomy took place, this treatment option started to become much more prevalent, and more surgeons were using this at a frequent basis without really a significant amount of data to guide their treatment or to really select patients appropriately. So we saw carotid endarterectomy performed in the 1950s, and then you can see from this graph here, it really took off, and in the 1980s, 1985 reached a peak of 107,000 carotid endarterectomies a year. And from this, we found that after reviewing some of the data, some community centers had stroke rates as high as 21%. So it really wasn't offering any benefit and was in fact causing harm. So this really is what called for more heavy research and randomized controlled trials to be completed on carotid occlusive disease so that we could better treat patients and select patients appropriately for an operation. One community center of note in Cincinnati was the highest stroke rate at 21%, and then a lot of other community centers were hovering around like the 15% range. And there are a few things that contributed to this high stroke rate. So a lot of these community centers performing carotid endarterectomy had low surgeon volume experience. So they would be performing maybe 5 to 10 carotid endarterectomies a year, whereas at some of these more larger academic centers, they'd be performing 50 to 100 CEAs a year. So obviously the stroke rates between those two groups were vastly different, with obviously the higher volume centers having lower stroke rates. So in terms of technical variation, there was really no standard technique for carotid endarterectomy, and there's no quality assurance. There's no one really reporting outcomes at these places. So people were just able to run wild a little bit, so to speak, in performing carotid endarterectomy. There were 3 papers that really showed this throughout the 1980s, and that's what called for more research. I do think it's interesting to think about this in the 1980s. There's kind of a little less oversight and people just performing this surgery without any real significant data, and it's similar to what we're experiencing now with carotid stenting. You see carotid stenting happening very frequently. There is data out there behind carotid stenting, but for instance, with TCAR nowadays, there have been no randomized controlled trials comparing TCAR to carotid endarterectomy, yet you see it being performed very prevalently in a much more safe manner than probably they did back then, though. All right. All right, so so after there was this big call for research, it birthed the two almost the most influential trials in carotid occlusive disease, which are NASCET and ECST. These trials came out in the early 90s, and they were looking at symptomatic stenosis and trying to determine a time frame in a patient population in which to intervene on. I think the NASCET trial was very significant. The trial was even stopped early just because they were seeing such great benefit in terms of treating carotid occlusive disease in these patients. They saw that with CEA, you could get your stroke risk significantly reduced. And so this actually called for an early end of the trial because the data was so overwhelmingly positive. So this led to performing CEA for asymptomatic patients with greater than 50% stenosis or symptomatic patients with greater than 70% stenosis. The number needed to treat here was 6. So I think that's a pretty impressive statistic. So one in every 6 patients are going to have a very significant benefit from a reduction in their risk of stroke from having this operation performed. And then in the ECST trial, it was the European version, basically, of the NASCET trial, and they came to the same conclusion, but a little bit less dramatic in terms of reduction of risk of stroke, and it probably is attributed to the more unhealthy lifestyle that we have in the United States. And then for asymptomatic disease, 2 of the biggest trials were the ACAS trial and the ACST trial. The ACAS trial showed it was looking at carotid endarterectomy with aspirin versus just aspirin alone. And at the time of treating carotid occlusive disease, aspirin was really one of the only medical therapies that you could offer a patient. So we've definitely come a long way from that. But in their study, it did show that there's a decrease in the rate of stroke when you had a carotid endarterectomy. So that was 5.1% over a 5-year period versus 11% with just aspirin alone. So this was another landmark paper that showed, even if you weren't having symptoms, performing a carotid endarterectomy could significantly reduce your risk of stroke in the future. And it really is what made carotid endarterectomy such a prevalent surgery in today's day and age. And I think over here on the right-hand side, I've listed a few points of what we consider today. So back then, all they had was aspirin, like I mentioned. And today, medical therapy has become a lot more sophisticated and advanced. We have statins, antihypertensive agents, and antiplatelet agents that we put patients on routinely that they didn't necessarily use back then. So their stroke risk back then was about 2.2% per year with these high-grade lesions, whereas now it's probably closer to about like 1 to 1.5%. And then the perioperative risk, during that time, in the medical arm, it was 2.2% to less than 1% per year, and then CEA still carries about a 1 to 3% perioperative risk, but the net benefit is still significant. In the CREST-2 trial, in the era of invasive modern medical therapy, this is one of the questions. Does adding carotid artery stenting or a carotid endarterectomy really offer a benefit to patients anymore with greater than 70% stenosis, especially since medical therapy has gotten so good? So while these trials were going on, carotid artery stenting was also being developed. The first carotid stent happened in 1980, but these stents historically had pretty devastating results. The stroke rates could be extremely high with these and really wasn't seen as a viable option until about 1997 when the first AngioGuard or basically filter for carotid stenting became available. With the first carotid filter that they started using, they noticed dramatically decreased events of microemboli occurring, which gave some promise to the field. And as it was continually improved and developed, we've seen this improve significantly over the years. The Sapphire trial was one of the first trials looking at carotid stenting versus carotid endarterectomy, and they took high-risk surgical patients, and it was a non-inferiority trial that showed that carotid artery stenting was not necessarily much worse than carotid endarterectomy in this patient population. And then CREST-1, which was the predecessor to CREST-2, which I'll talk about today, it was looking at carotid artery stenting versus CEA, and it showed that carotid artery stenting had more periprocedural strokes at 4.1% versus 2.3% for carotid endarterectomy. However, CEA had more periprocedural myocardial infarction at 2.3% versus 1.1%. So it kind of came up with a debate of, which is worse, a periprocedural stroke or an MI. So it didn't necessarily improve the rates of carotid artery stenting because the data just wasn't significantly overwhelming. And then in the more modern era in 2020, we have the TCAR and Roadster 2 trials. This is looking at transcarotid artery revascularization with flow reversal and using direct neck access. So you don't have to traverse the aortic arch in order to deploy a carotid artery stent, which significantly reduces your risk of stroke and death in carotid artery stenting. All right, so in talking about the CREST-2 trial, this is a somewhat controversial trial that has come up recently. It was recently published in 2025. And this was really trying to answer the question of, stenting asymptomatic carotid artery stenosis with greater than 70%, carotid artery stenting versus carotid endarterectomy, both with optimal medical therapy. All right. And, this is somewhat controversial because, our medical therapy has improved so greatly that we even wonder if carotid endarterectomy or carotid artery stenting provides any significant benefit over medical therapy alone. And that's something I alluded to a little bit earlier. Let's see. So in the CREST-2 trial design, it was really two randomized controlled trials included within the same study. It was carotid artery stenting with intensive medical therapy versus intensive medical therapy alone. And then in the other arm is carotid endarterectomy with intensive medical therapy versus intensive medical therapy alone. So each trial had significant amount of patients enrolled. And obviously in one trial, the intervention was the carotid artery stent with an embolic protection device. And then in the other carotid endarterectomy trial is just a carotid endarterectomy with a standard technique. The operator qualification I thought was an interesting point to bring up between these two studies. The operator qualifications in the carotid artery stenting trial was much more rigorous. So the operators in this arm had to complete at least 200 carotid artery stents within their career, and they had to have specific rates of stroke and periprocedural complications within a certain range. So about 300 people applied to be one of these operators, and only 9% of them were accepted after reviewing their cases. In the carotid endarterectomy trial, the qualification to be one of the operators in this arm of the study was that you just have had to perform 50 carotid endarterectomies in your career over any time period, and about 90% of these applicants were accepted into the trial. So I think that raises a point of, you're looking at an expert interventionalist performing a carotid artery stent versus just, an average vascular surgeon performing a carotid endarterectomy. So it's something to keep in mind. The main result from these two trials is that the carotid artery stent plus intensive medical therapy showed a reduction in the risk of stroke at 2.8% over a 4-year period versus 6% with just intensive medical therapy alone. And this was the primary endpoint for the study, was looking at stroke over a 4-year period. And then in the CEA trial, this actually didn't reach statistical significance, but it showed that the 4-year stroke rate was 3.6% in the carotid endarterectomy trial with intensive medical therapy versus 4.7% at 4 years. But as I mentioned, this wasn't statistically significant, so can't really draw too many conclusions based off of that. And I think a lot of people inappropriately view this as a head-to-head trial against carotid artery stenting and CEA, when in reality, it was two randomized controlled trials with different patient populations being performed at different medical centers all across the country. And here are some of the more of the results. And I think something interesting to point out is that in the carotid artery stenting trial, the stroke rate for intensive medical therapy alone was 6% at a 4-year period versus 4.7% in the carotid endarterectomy arm. So I think that goes to show that even just treating with medical therapy, there's a significant difference in the rate of stroke. And I think that goes to highlight that these two groups of patients that were being compared weren't necessarily equal in terms of comparing it to the intervention. So I thought that was an interesting point. In addition to that, I'll show you some of the controversies and debates on the methods of using of this study. So there, like I mentioned, two separate trials which can't necessarily be directly compared. There was the asymmetric operator credentialing, which I alluded to earlier. And then I think the intensive medical therapy that they used was really not something that's generalizable to our everyday patient population. So they had greater than 90% bi-monthly phone coaching. They would receive a phone call from a health coach multiple times to ensure that they were adhering to their anti-lipid medication, antihypertensives, that their blood glucose was controlled. And it is just not something that we necessarily have for our everyday patients, especially in a community setting. The patients also got free medication, and I think that's also something that can be a significant barrier to treatment in our patient population. So I think that's just something to keep in mind, is that the stroke rate in just the medical therapy group alone might even be lower than what we see in our general population, just because the actual medical management was so intense and was so absolutely perfect with a greater than 90% adherence rate. And this trial I think offers a lot of benefits, but it's important to keep in mind that this is just one of 8 prior randomized controlled trials, which showed previously that carotid artery stenting was inferior to carotid endarterectomy. So I think it's definitely another set of data to kind of put in your toolbox, but not necessarily something to replace all the randomized controlled trials that have gone on before this. I think it's also important to note in the carotid artery stenting trial, they were doing transfemoral carotid artery stenting and not TCAR, which is really something that is more widely used today. I think some of the positives that came from the trial is that this is level one evidence, and it did show that a statistically significant difference, that intervening on carotid artery stenosis did have a reduction in the risk of stroke. So that was one of the questions they were looking at answering. And in the carotid artery stenting arm, using a carotid artery stent reduced the risk of stroke by 53%. So I think that's something that's definitely a positive that came from the study and showed that we still should be intervening on this disease process. I think the CEA trial was underpowered, but it wasn't necessarily disproven. So the CEA trial was powered for 7% medical arm event rate, and we saw that it was at 4.7. So a lower event rate is really what reduced its statistical power. And if that stroke rate had been a little bit higher, or if there were more strokes in that medical therapy arm in the CEA trial, we might have actually seen a statistically significant difference. And then I think another positive from this study was that the periprocedural safety has really come a long way since we started first performing carotid endarterectomy. So in both arms of the trial, they achieved a very low periprocedural event rate, and I think that's definitely a win for the field as a whole. And I think, although this study I think was really good, I think it kind of confuses things a little bit, and I think a lot of people out there are saying that carotid artery stenting is better than carotid endarterectomy, but really you can't really draw that conclusion from this study simply because it wasn't a head-to-head trial. It was really two separate randomized controlled trials with obviously different patient populations, as we saw in just the medical arms, with a significant difference between even just the two medical arms. I think something also that's worth pointing out, in the CREST-2 trial, in the carotid endarterectomy arm, their stroke rate was about 1.5%, whereas based on national VQI data, the stroke rate nationally is 0.9%. So that goes to show that the stroke rate really wasn't even up to the standard of care necessarily in the general population when performing carotid endarterectomy. So I think there are a lot of good things that we can take from this study, but it also isn't definitive and shouldn't replace your framework for thinking about how to treat carotid occlusive disease. I think a good decision framework is for symptomatic disease with greater than 50% stenosis. The gold standard is always going to be a carotid endarterectomy within 2 weeks. This is level A evidence, and that's definitely not going to change anytime soon. And it shows that really, if you can perform a carotid endarterectomy within the first 48 hours, it even has a number needed of treat of 3 versus 6 for a 2-week period. So I think regardless of any study that's been out there, we'll always be treating symptomatic carotid artery stenosis. I think for asymptomatic, that's really where most of the research is being put nowadays, and looking at whether medical therapy alone could even compete with intervening on carotid disease. And I still think that there's definitely a role for intervening on carotid disease and revascularization. If your patient has a life expectancy of greater than 5 years and is fit for surgery, or if there's a high-risk plaque that might cause tons of microemboli like we kind of discussed earlier, or if there's poor adherence to medical therapy. So if your patient is not one of these people who can maintain a greater than 90% adherence to their medical therapy regimen, they may be someone who would significantly benefit from carotid endarterectomy or carotid artery stenting. So I think really you have to consider your patient more closely and their specific risk factors that would make them a good candidate or not for carotid artery revascularization. And I think that's a good point to take away from the study is that, we don't really live in a perfectly controlled environment like there was in the study. So I think you have to take these things into consideration and just try to make a decision with your patient about what's best for them. For asymptomatic disease, medical therapy is still going to be the preferred route with less than 50% stenosis. These patients, we've seen that we can achieve really low stroke rates with medical therapy alone. So if your patient has less than 50% stenosis and is asymptomatic, medical therapy is probably the best route to go for that and will significantly reduce their risk of stroke in the long run. I think some of the future directions of carotid disease is pretty exciting to me. So I think now we're really more of like a stenosis-based or degree of stenosis-based guidelines where we intervene based off just purely the level of stenosis. Whereas I think in the future, as imaging improves, we'll start to move towards a plaque biology-based intervention where with high resolution imaging, we may be able to identify more significant, more risky carotid lesions that would require intervening even if they didn't have a high degree of stenosis. Some studies are out there showing that intraplaque hemorrhage, creating microemboli, put a patient at 5 to 6 times higher risk of stroke. So I think, considering things like that, even if they don't have a high degree of stenosis, will be really important in the future. As TCAR gets better, there's a Roadster 3 trial ongoing, which is a randomized controlled trial comparing TCAR to carotid endarterectomy. So I think that'll be something that's really important to see the results of and see what the rates of stroke are and periprocedural stroke rates are in those two interventions, which could change the future direction of our field. And then, as we come up with better medical therapies in the future, as we're developing surgery, we're also developing more sophisticated medical therapies like PCSK9 inhibitors, which have been shown to really significantly reduce the levels of LDL and actually creating plaque regression in some cases, which is one of the first times that's ever been observed in a patient. And then artificial intelligence, I think, will help in some of these imaging modalities and maybe be able to help better analyze high-risk plaques or lesions that may give us a better sense of when to intervene, even if the patient doesn't have a significant degree of stenosis. So I think the key takeaways for this presentation is that carotid endarterectomy for symptomatic disease is unchanged. That's something that is a high degree of evidence, and I think performing a carotid endarterectomy within 2 weeks of a TI or a minor stroke shows significant benefit, and that likely won't change. And then medical therapy has transformed the risk landscape. So as I mentioned, in the ACAS trial, the stroke rate was 2.2% a year, and they were just using aspirin alone. And now we have all these antihypertensives, blood glucose management options, statins, and really fancy antiplatelet medications that significantly reduce your risk of stroke with medical therapy alone, which will be promising in the future, especially as those things continue to be developed. And then in the CREST-2 carotid artery stenting trial, like I mentioned before, this is level 1 evidence, and it showed that intervening on carotid occlusive disease still does show a benefit in reducing the risk of stroke long term. So it was a 53% reduction. So I think that was one of the main questions they were trying to answer in this study, and I think they successfully answered that intervening is still beneficial in patients. And then the CREST-2 and the CEA arm of the trial, although it was not significant, it wasn't disproven, meaning that there was still a positive trend in benefit for intervening on carotid occlusive disease with an endarterectomy. But since the study was underpowered and a non-significant p-value, we can't make many conclusions from that, but we do know that there's benefit from it as well. And we also have 8 prior randomized controlled trials showing that there's a significant benefit with carotid endarterectomy. So it really just reaffirmed those results. And I think a lot of the controversies around CREST-2 are legitimate, and it's just something to keep in mind and as you move forward and consider treating your patient with carotid occlusive disease. And then, the final point is that personalized medicine is definitely the future, and I think we'll be making decisions on treatment modalities really based off patients' individual characteristics, risk factors, and lesions. And that's my presentation. These are my references. Welcome any questions from y'all, and thank you for letting me present.
Thanks, Sam. That was a great presentation. Yeah, I think you hit pretty much all the main points that I've heard, when discussing with others as well. I think the biggest takeaway that is not immediately apparent is, like you were saying, it's actually in favor of more of the CEA intervention with asymptomatic, because even if patients all do the right thing, there's still a benefit, right? And it's like, you're getting to the point where it was down to the wire, but in reality, it's much less compliance than what they showed in our communities especially, and so the benefit is probably much larger. And so this was really the question, like, should patients be undergoing this procedure, open procedure for asymptomatic disease? And to me, that's the more important takeaway, less so that, okay, we proved that the non-standard of care stenting technique is safe. I'm not sure that was a huge insight from this, but I think they got this started before TCAR really came out, and they just had to keep going essentially.
Yeah.
And like you said, you can't really compare those two trials going on within the study. They're different, they were modeled differently,
Yep.
and it's really just two bodies of information that they were able to come out with. And I think they knew that if they stuck with just stenting, people are going to say, all right, well, now we have something better anyway, so, what's the point?
Yeah, I agree. And I think that's an important point to raise, is that they really should be viewed as 2 separate trials going on concomitantly, because there are different inclusion and exclusion criteria. So like in the carotid artery stenting arm even, they really almost, try not to put it so bluntly, but it's almost like they cherry-picked the best cases. So the lesions had to have very specific characteristics that would make them optimal for being treated with a stent. So I think it would be really unjust to make a statement like carotid artery stenting is better than carotid endarterectomy, or even, saying that I think all you can really say from it is that it's a viable option but I don't think you can say one is necessarily better than the other. I think there are just too many confounding variables.
Yeah, exactly. And I think the other interesting thing that will come out hopefully in the future with this is like determining exactly which plaques are high risk that are asymptomatic but may become symptomatic. And I think with the like genomic testing and then the also the imaging, these advanced imaging algorithms that kind of characterize the plaque, I think that will honestly become more of the important discussion when determining which asymptomatic patient should have surgery or not.
Yeah,
But
there's some studies out there right now showing that if you image a plaque that has thrombi associated with it or an ulceration associated with it, even if they're at like 40% stenosis, those patients are at a significantly increased risk of developing a stroke from that lesion. So I think you're right. I think in the future we'll probably be intervening on patients with even a less degree of stenosis, but with higher risk lesions. So I think medicine as a whole is kind of heading in that direction of personalization, and I think we see that in vascular surgery as well.
Okay, thank you so much, Dr. Berding.